Hi, my name is Mira Grover, and thank you for watching this video on opioid withdrawal and acute pain management. This is just a brief video to go over some of the basics, and if you have any questions or concerns, please make sure that you contact an addiction medicine specialist themselves, either through Specialist Link or Rapid, to try and make sure that you get any patient-specific advice. Please remember that everything that we do for patient-centered care involves patient education and consent. So please involve your patients with every decision that you're making and make sure that they consent and get their opinion on it. Very important for addiction medicine to be checking your biases and managing your countertransference. Addiction causes a lot of stigma, and we all have that inside us as well. So please make sure that this is not passing down to your patients. Of course, these are educational videos, not patient-specific advice. So you are responsible for your own practice. And I do not have any conflicts of interest to disclose. Okay, so opioid withdrawal is a pretty common thing that we see in acute care or in the community. It is medically contraindicated to encourage opioid withdrawal without providing OAT. So OAT is opioid agonist therapy. That's things like Suboxone, methadone, Cadian. The reason that it's medically contraindicated is that it increases our risk of illicit use. And if you're a patient and you're going in cold turkey, much more likely to relapse and then be forced to use illicit substances and then die by overdose because of the lowered tolerance that comes with withdrawing and going cold turkey. So really important to provide that education and ensure that if a patient is still like, no, I don't want any OA2E, I want to go cold turkey, that is clearly documented, that you have advised them the risks and that it is against medical advice. There is also iatrogenic opioid withdrawal, which does happen much more than it should. And this is either discontinuation of illicit opioids without opioid replacement. So if a patient comes in and they're sick, they have a pneumonia, they have a broken leg, their earlobe fell off, whatever it is. So they're in hospital and they normally would use illicit substances, and now they've stopped because they're not able to access those substances in hospital. So that is an iatrogenic form of opioid withdrawal. We have to make sure we're treating that. Also, similarly, so if a patient comes in and they were on prescribed opioids in the community and they have all of a sudden been stopped, so whether that's a family doctor stopping patient supply, like cutting them off, or whether they come into a hospital and their methadone prescription didn't get renewed when they were in hospital, whatever it is, there are lots of ways that we can cause opioid withdrawal. And again, that is medically contraindicated. So we're going to just be making sure that we're treating that. Remember, of course, that opioid withdrawal is teratogenic and it can cause fetal demise. So anybody who is pregnant who is in opioid withdrawal, that is a medical emergency, and we are going to deal with that immediately. Okay, so sometimes patients are able to let you know if they're in opioid withdrawal or not. We have some objective scoring systems. So we've got the COW system, which helps us to get an objective sense of if patients are in withdrawal and how much. And then there's the SAL score, which is sort of what patients can use to tell us if they think they're in withdrawal. COW scores do not work if you just sort of are like, I think they're a little bit anxious. You got to ask the patient as well. Patients who have chronic opioid use disorders may have the ability to hide some of their withdrawal or manage it well. And that part of that is survival in the community. So if you look like you're in rough shape, or if you look like you're in withdrawal, you become a bit more of a target. People know that you're more desperate. So people do have that ability to hide opioid withdrawal. Really, really important to make sure you're asking the patient, do you think you're in withdrawal? We can do some symptomatic treatment of opioid withdrawal. So symptomatic treatment, we can use things like clonidine for anxiety and the sweats. We could use gabapentin for the muscle aches that come with it. We could use things like Seroquel for sleep. Whenever we're doing symptomatic treatment for opioid withdrawal, these are off-label treatment modalities. And we always want to make sure that the patient is aware they're off-label, the patient is aware of the risks of using them. So clonidine is like an old blood pressure med. You're going to have lower blood pressures potentially, like, those kinds of things where the patient is fully aware of all those things. And then I actually write right on my prescription, these are for withdrawal management only. These are not long-term medications, because, the next doctor goes on Netcare and they say, oh, this patient had a gabapentin prescription 2 weeks ago that's run out. I'm going to refill it. So they may not know that you had only prescribed it for a specific period of time. And so sometimes patients do end up dependent on these medications. Okay, so when we're looking at a patient who's come in and they're in opioid withdrawal, and you're trying to get a sense of how do I treat their opioid withdrawal, getting a sense of their opioid debt is really helpful. It's very tricky to estimate opioid debt from illicit substances, and I would definitely involve addiction medicine in any of these kinds of conversations. But to kind of give you a bit of a estimate, so like a point of fentanyl is 1/10 of a gram of fentanyl. That's like 100 milligrams of fentanyl, which is a lot of fentanyl, right? Because when we're prescribing, we're talking about micrograms. So milligrams is several orders of magnitude different. Some people use like 2 to 6 points a day. Some people might use up to 3 grams a day. Some people use more than that. Some fentanyl also includes other things like carfentanil or benzodiazepines. So it's really hard to know. So we're not saying like for sure this is the exact morphine equivalent, but just giving us like a broad ballpark view. Well, a point of fentanyl is about equal to 10,000 morphine equivalents. Now, we're not just going to give someone 10,000 milligrams of morphine, but it does tell us, like, well, if I give them like 20, they're probably not going to overdose. So cross tolerance doesn't quite work that way. So, for example, if someone comes in, they use tons of illicit fentanyl, we still don't start their methadone at 100. We still start their methadone low because they could still develop opioid toxicity from a different opioid. Their tolerance is only necessarily to a specific opioid, but it just kind of gives you a sense of they got some tolerance in there, and if you start them at 40 milligrams of methadone, let's say, and they still have a lot of withdrawal, you're not going to be surprised. You're going to be able to supplement with whatever other medication like Cadian or whatever else you need to help manage and mitigate that withdrawal. Okay, so you are unlikely to overdose someone with prescription opioids if they are tolerant to high doses of fentanyl. You're not going to try to do that, but sometimes when patients come in, we're starting them, if we're in acute care, we start them at like 0.5 milligrams of hydromorph and they use 3 grams of fentanyl. So if you're going to start that low, what you're going to do is reassess very rapidly. So 0.5 milligrams of hydromorph, how did that feel? You feel nothing? Okay, let's increase it. Double it to 1. How does that feel? Nothing? Double it to 2. Nothing? 8. I'm very comfortable starting much higher doses when I'm in hospital as an addiction medicine specialist. But if you are just learning, and you're not comfortable, start low, but reassess like every half an hour or an hour to make sure that you are properly treating someone's illicit opioid withdrawal. Because if you are under therapeutic dosing levels and they are not getting out of withdrawal, they are more likely to leave AMA, not get their whatever they came in for treated, and they are more likely to use then illicit fentanyl, which their tolerance may have lowered depending on how long they kind of white knuckled it in a hospital, and more likely to overdose on leaving hospital. So again, be very careful. We can cause harm by undertreating opioid withdrawal. Also, a pro tip, get a good sense of why a patient is sleepy. Please see my other video on taking a good addiction history. Meth withdrawal can look like opioid intoxication in the sense that patients look very, very sleepy. They are drowsy, they're very difficult to rouse, and that can hide opioid withdrawal. Key for this, respiratory rates. If they have a fast respiratory rate, this is not opioid toxicity. So if we undertreat opioid withdrawal while someone is going through meth withdrawal and they're a little bit drowsy from their meth withdrawal, but we're undertreating their opioid withdrawal, they're going to tell you, like, I'm in a lot of pain, I'm in aches. And you might go by and be like, well, they're sleeping. It's not that bad, but that's not the same thing. So if we don't treat their opioid withdrawal well, then as soon as their meth withdrawal starts to fade, they're up and out of there. Their tolerance is really low, high risk for opioid toxicity events. So please make sure you are treating their opioid withdrawal. Pain management in acute care, of course, we're going to try and avoid all opioid withdrawal. I feel like I said that several times. I will continue to say that several times, unless we're meeting the patient's goals or they have acute needs for naloxone. So our secondary goal, of course, is to manage the pain appropriately. Please consult addiction medicine if you have any questions or any issues with this. So patients with an opioid use disorder typically need more, not fewer opioids when the patient is in hospital, right? Because their tolerance is quite different. Patients do feel a lot of stigma when having to ask for those pain medications. So we try and make sure we've got as much medication scheduled as we can so that patients not having to ask for PRNs. And we're not relying on having the nurses have to assess every time whether or not the patient should receive a PRN. Um, we already talked about starting low with a big range to titrate quickly. The more less comfortable you are, the more often you need to reassess. We're also going to consider short acting plus long acting. So if someone comes in and you're just not sure what's going on, or they have pneumosepsis, or you're like, you know what, I'm not going to start them on methadone quite yet because they are still like quite respiratory depressed or they're quite sick. At that point, we're going to just rely on those short acting. So both short acting and long acting will treat opioid withdrawal. Short acting will just treat it for less time. So we have to do it more rapidly. Long acting can treat it for longer, but then of course the risk is that if they do go into respiratory depression, that's going to stick around for a little bit longer. So if you're uncomfortable, start with like low dose long acting and really ramp up the short acting until you've got a sense of what their tolerance is. Okay, and then of course, please remember to take into account any concurrent benzo or alcohol use because that, of course, can contribute to respiratory depression, can contribute to withdrawal symptoms as well. That's all I got. Thank you very much for listening to this short talk on opioid withdrawal management, and I hope that it was helpful.